A lot of training programs don't teach you how to bill properly. It's something that nobody wants to think about. Whether a patient should be billed at a level 3 or 4 or 5, the difference might be as small as documenting your own interpretation of an MRI, but there could be more than a twofold difference in payment. There's an app called BillUp, which takes the thinking out of billing, and I use it when I'm closing notes, and in a few taps I can calculate the best level of service, or make sure my note has enough documented. Just search the App Store for BillUp. BillUp, so you can focus on patient care. Last week on the show, I talked at length about how doctors die differently. Specifically, how we as physicians utilize end-of-life care services differently from that of our patients. How we seem to be less interested in receiving life-sustaining efforts, like CPR or mechanical ventilation. How we're more likely than non-healthcare professionals to seek out palliative care and achieve quality rather than quantity of life. This week, we are exploring how doctors die differently using a different lens. And this one is a little more sobering than what we discussed last week.
Why are we finding so many dead doctors in hospitals? You know what I mean?
Specifically, why so many doctors who die by suicide?
I mean, there's got to be some investigation. I mean, it's just odd.
This is Dr. Pamela Wible.
I'm a family physician practicing in Eugene, Oregon. I'm author of Physician Suicide Letters Answered, and I am an advocate for physician suicide awareness and prevention.
And not just an advocate, but really a leader in the field who has brought much of what we know of physician suicide to the forefront. For instance, did you know that of the 700,000 or 800,000 physicians in the US, 400 die by suicide every year? Maybe that number seems small to you, but that's 7 school buses full of medical professionals who've dedicated their lives to the service of others. Gone. Every year.
Although once they start to think about it, they understand, oh, wow, I can see why doctors would be stressed. Oh, yeah, that does make sense. Watch people die for a living.
I asked Dr. Wible to join me on this week's program to talk about her experience advocating for overworked physicians and to share some of her insights. In the story of how she got to where she is today and the kind of clinic that she operates, it might make you rethink your own clinical practice if you're a physician.
Well, I started it out of my own absolute frustration with the practice of medicine. I felt like I had chosen the profession for the right reasons. I felt like this was pretty much my destiny from birth. I feel like I was born to be a healer.
Does story sound familiar to you? I feel like it would to most of us, heeding some noble call to help out others. But like most of us have experienced, the practice of medicine hasn't been as glorious as we had originally envisioned.
And it was so frustrating to me because I did not go through all this training to be a factory worker, processing widgets. These are human beings with feelings, and I wanted to be able to relate to my patients on the, emotional, spiritual, physical level, and that's impossible, as you might probably understand, in a 5 to 10, even 15-minute visit.
So Dr. Wible revisited what her calling had originally meant to her, and to re-engage with her patients on a personal level, to disavow the kind of cookie-cutter assembly line practice that had come to shape our current healthcare system. And this led to what she's called the ideal medical care movement.
And so, out of my frustration, after 6 jobs in 10 years looking for sort of that employed position that would make all my dreams come true, I found that there was really no employed position that would allow me to practice medicine in alignment with my highest values. And so I decided to host a series of town hall meetings in my community and invite my community to design their own ideal medical clinic. So I literally wanted patients to write my job description for me, and I would work for them.
So Dr. Wible held her town hall meeting, a couple of them actually, collected a few hundred pages of notes and requests from her current and future patients, and she got to work on what people wanted.
Oregon, where I live, people really just wanted me. They wanted eye contact. They wanted a small office,
Nothing fancy, just a homey environment in a 280 square foot office space.
And I see one patient at a time for 30 to 60-minute visits,
which she does entirely on her own.
I have no staff. I do all the billing on my own. I submit to insurance companies. And it's just like I've removed all the unnecessary infrastructure that exists in most primary care clinics. And I'm able to really have what I call relationship-driven care instead of production-driven care, which I think is kind of the dominant model around the country.
And maybe you'll find it ironic, me opening up a show by talking about how doctors are burnt out, overworked, and they hate their profession. And now Dr. Wible and I talking about how you can solve this problem by committing yourself to doing more work.
And so the ideal medical care movement, so to speak, is other physicians around the country are taking back their profession in the same way that I have, in that they're inviting their community to collaborate with them in designing these ideal clinics all over the country. And so it's really, really exciting to watch them blossoming everywhere.
Most of these physicians, about 500 so far, have learned how they can accomplish this on their own through one of Dr. Wible's biannual Live Your Dream retreats. And not to mention the hundreds, if not thousands more physicians who have come across her writing on Kevin MD, her talk from the TED stage, and her blog at idealmedicalcare.org, or her own podcast, Pamela Wible Talks. I had the most interesting conversation with my wife last night about what it means to go into medicine, and I think you really have to see it as kind of a calling. You have to be so motivated to do this, to devote yourselves to patient care and to clinical medicine, because you go through so much crap and so much struggle.
Absolutely, yeah. Yeah, if you go into it for the wrong reasons, or people who are pressured, by sort of the family of origin wanting their trophy child to be a doctor, it's just really dangerous. That's actually a risk for suicide, is just all these external pressures that people feel, and when they don't necessarily pursue medicine for their own soul's purpose, it can be tragic.
Yeah, it can be tragic. A lot of people in the medical profession are almost forced into this kind of a career because of family obligations or some other predetermined plan. And if they had the choice again, half of doctors in 2012 wouldn't go back and do it over. Many doctors won't even recommend it to their own children nowadays. As for me, I actually didn't know there was another career out there which could be as satisfying. My family always told me, Jim, you like science and you like math. You're going to be the doctor in the family. And honestly, I consider myself incredibly lucky that I found such satisfaction in this career choice. So many of my friends just don't like their jobs. And
those are friends within medicine, you're saying?
Yeah, friends within medicine. Yeah. Do doctors have other friends? I wish that I had other friends.
Oh, that's hilarious. Yeah, right.
Yeah. And when I talked to some of the residents that I work with on a prior show, one of them didn't call it burnout, although burnout's been kind of a popularized term in the literature. To that resident, burnout isn't so black and white, and he says it was more of a smoldering, kind of a spectrum. And you don't use burnout either. How do you describe what doctors experience?
Well, I think in residency and during training, what they're experiencing, quite frankly, is human rights violations. The whole idea that somebody could work, 28 plus hour shifts and be able to handle the type of life and death situations that we're placed into is just absolutely insane. And it is clearly a violation of our human rights and the rights of our patients to be asking us to make decisions when we are, at the equivalent level of being, drunk, literally. After 24 hours of being awake, you have a blood alcohol level equivalency of, something that would get you pulled in for your DUI.
For what it's worth, the ACGME and local institutions have made recent dramatic changes to duty hour requirements for trainees, which should have been highly controversial. Just last year, the ACGME actually reversed a prior decision, which had previously limited work hours from 24 to 16 in a day for first-year residents, citing that patient outcomes were not universally affected by more consecutive hours spent in the hospital, and that the increased number of patient handoffs between providers carried some additional risk. Even so, like Dr. Wible said, sleep deprivation results in similar impairments of physical and mental performance, as does alcohol intoxication. But Dr. Wible was wrong here. You don't need to be awake for 24 hours to have the reaction time, or coordination, or memory function of somebody who has a blood alcohol level above the legal limit. Apparently, it only takes 18 hours of wakefulness to get you there.
It's just impossible to think when you're up for that long. And I do think there is a lot of bullying and hazing and sexual harassment and other sorts of things that happen during residency training that is really toxic. And, I don't think it fits into the category of just this trash can label burnout that's overused. And the problem with that word burnout is that it blames the victim. And these people were not burned out, like say they were real estate agents or, in another field, they wouldn't be quote unquote burned out. They would have normal working hours, 40 hours a week, and they would be in working conditions that are protected by OSHA and the ADA, and they would be protected by the laws that protect everyone else in this country. You know what I mean? Somehow residents are not protected by the same laws.
Now, this was an interesting point, that resident physicians aren't covered under the same protective umbrella as other classes of employees, because they aren't workers. I had to double check this, and as it turns out, the role of resident physicians in the workforce was only recently ambiguous. In one of the more famous legal cases, the Mayo Foundation for Medical Education and Research versus the United States, which reached the U.S. Supreme Court in 2011, the question was raised, should resident physicians be treated as workers or as students? To give you some historical context, the Federal Insurance Contributions Act, FICA, had required hospitals to pay Social Security taxes on residents since the 1930s. And all hospitals did this, except for the University of Minnesota, which thought that its residents would be exempt from these taxes. The University of Minnesota believed in the word of the law, that legally anybody who's under the employment of a university who also studies at the university would be exempt from paying Social Security taxes. Well, the government didn't like this, missing out on years and years of an institution's Social Security taxes for resident employees. And in the 1990s, the U.S. sought to reclaim these unpaid taxes from the University of Minnesota. The U.S. government sued the university, but the government lost. Resident physicians were now declared students, and technically now they became exempt from paying Social Security taxes. Now you can imagine the response to this. Every other academic hospital with residents wanting a piece of the pie, and a number of these institutions quickly followed suit, demanding the government reimburse the university for these unlawful taxes. And the U.S. Treasury paid out. This was no small chunk of change, mind you. This amounted to about $700 million annually for U.S. hospitals. Eventually, because of these numbers, this decision was reversed in April of 2005. Residents were no longer students if they worked more than 40 hours per week because they did not receive the same type of traditional education that undergraduate and graduate students were receiving. Residents now became workers. But Dr. Wible was still right about one thing. Although safeguards were put in place by OSHA, regulations which until recently required interns to work no more than 16 hours per day, it doesn't feel like residents are being protected as workers.
And so that's something else that I think is really important that would be sort of in the realm of a human rights violation is that we experience trauma and by just witnessing what goes on with human suffering and death all day long. And so we have this vicarious trauma, and we should be allowed and even supported during our training and beyond with on-the-job mental health care just as sort of maintenance. You know what I mean? You shouldn't wait until you're really, having a meltdown and being thrown into the lap of a psychiatrist years later with depression and suicidal thoughts. I just really feel like in medicine, we need on-the-job mental health support as sort of a normal way to help our doctors function.
And maybe if we spent more time on prevention, as we try so hard in all disciplines of medicine, we wouldn't see so many of the long-term, irreversible consequences of physician abuse.
Well, I personally had the experience of being a suicidal physician, so I can speak, in first person about this.
911, what's your emergency?
And it was, for me, 100% occupationally induced. It was that frustration that I felt before I had the epiphany that I could lead a town hall meeting and sort of open my own clinic. I felt sort of in a straitjacket, handcuffed and kind of locked into these big...
I don't have to say it, but this kind of mentality is all too common. Suicidality, I mean. According to the American Foundation for Suicide Prevention, every year we lose 300 to 400 physicians to suicide. That's one a day. Last week on the show, we talked about how physicians have learned from patient experiences that they don't want to suffer through a terminal illness, how they're more likely than their parents to decline life-saving interventions and life support if these things won't return to a decent quality of life. They would just rather die. And now we're saying that physicians would just rather die. Period.
Model for myself, but I think the reasons why other physicians feel suicidal, they come from all sorts of avenues. They could be suicidal just in residency due to having a really toxic malignant attending. Sleep deprivation in and of itself can make your thinking process altered and destabilize you. Other people are coping with their trauma and the pain of what they've witnessed at work by, drinking and taking antidepressants, which they might get outside of really seeing their own therapist. I think that there's a lot of pain, obviously, going on that physicians are bearing and carrying with them throughout their careers. And I think ultimately it comes out in poor parenting, inability to really have successful marriages, alcoholism, other problems with drugs. Ultimately, then many of them can decide to end their lives tragically.
Anytime someone takes their own life, it is a tragedy. It doesn't have to be a tragedy just among doctors. But doctors are worse about this than others. And it has to make you wonder why. According to a 2004 meta-analysis, Schernhammer and Colditz reported that physician suicide rates are remarkably higher than those of the general population. And this divergence appears to begin around medical school, when rates of female physician suicide begin to climb. After medical school, according to these pooled data from 25 studies, the rate of suicide among male physicians is now 40% greater than male non-physicians, and the rate of suicide among female physicians is 130% greater than female non-physicians. It shouldn't surprise you to hear this when you come to learn that the incidence of depression climbs from 3% to 27% by the third month of intern year, or that an intern's thoughts of dying grow by 370%. And whether it's because you're overworked, or you've seen people in the worst states of their lives, or you're being insulted or abused by your supervisors who expect you to just suck it up, there's no way that this job won't get to you.
On a daily basis. All that sadness pushes many to the point of taking their own life.
Research shows that almost 30% of resident physicians suffer from either symptoms or a diagnosis of depression.
Depression researchers have found medical practitioners are more likely to take their own lives than others in the community.
The 73-year-old doctor was found shot in his St. Pete office this morning. Police found a gun, but no note.
It doesn't really matter whether it's an actual diagnosis or just significant symptoms. It means that they're suffering, they're not functioning well in their personal roles, they're not functioning well in their professional roles.
But research suggests many doctors suffering from anxiety and depression are not seeking help. A review by Beyond Blue has found some believe that doing so would hurt their careers.
When I started this 20 years ago, you would have been laughed out of the room had you even discussed this.
And some are self-medicating with prescription drugs.
Sometimes that medication is potentially appropriate, as with antidepressants. Often it is not.
And what's interesting about these doctors, many of them who die by suicide, they're functioning at work normally, to the observer, the patient and the nurse, and nobody in the clinic would have had any idea that after that successful surgery, Dr. So-and-so would go in the back room and hang himself in the medical records department, or, that this anesthesiologist would be found, with an IV inserted and overdosed in the OR. Or the closet, or go home and shoot themselves in the head. So it's a huge problem that is not being addressed.
Let me break in by saying that it's not necessarily that these physicians are walking around suicidal all day, and then all of a sudden they're found next to a bottle of pills. That'd be horrible. It turns out that many victims of suicide in medicine don't make that decision until just a few minutes before it happens. While people who think more about suicide are more likely to attempt ending their lives, Dr. Wible's experience with suicide attempt survivors is that most doctors don't think too long about it before actually committing the act.
Other people, I've interviewed a lot of physicians, mostly male, by the way. For every woman, we lose 7 men on my informal list here of 900 cases or so. And I've interviewed a number of male physicians who've survived their suicide attempts. But however, they survived despite all odds. And interestingly, I asked them, how long was it between when you decided, you made that decision to kill yourself and you actually followed through with it? And they each said something like 3 to 5 minutes.
Only 3 to 5 minutes. I mean, for almost all these people's lives, they were doing just fine. Family thought they were fine. They never imagined they'd ever kill themselves. And this kind of labile thought process, or decision-making, and suicidal thoughts, going from 0 to 60 almost instantaneously, turns out to be a huge risk factor for suicide attempts.
I mean, it was very impulsive. I mean, like they got to this breaking point, and then they just jumped, slit their wrists, overdosed. That's scary because that means, think about what that means.
That means that every doctor that I'm friends with now, could be fine, and then all of a sudden 5 minutes later, they're gone.
Right.
That's horrible.
I know.
Obviously, there are other risk factors too. It's not typically a spontaneous, horrible decision. Known risk factors among suicide victims include depression, obviously, sexual harassment, which has only surfaced more in recent months, alcoholism, particularly among women for some reason, and drug abuse, which we see more often in psychiatrists, anesthesiologists, and ER physicians who become suicidal. Furthermore, and this is horrible to think about, physicians appear to be better at selecting more effective methods for suicide than non-physicians. Their success rate, if you can call it success rate, is astoundingly high. Doctors know how to make life end. Although Dr. Wible herself has not meticulously studied suicidality among physicians, she's not conducting any formal longitudinal cohort study. She has made herself available to physicians at risk. She runs a sort of hotline for doctors and medical students who are having difficult time with work or with life.
And I'd end up on the phone, at 11 p.m. for 2 hours with, a resident and across the country. And so I've just
And she's taken it upon herself to spearhead this awareness campaign by educating entire groups of physicians.
And then I do also have a teleseminar and a retreat, which is helpful, I think, for people who want to.
And obviously, Dr. Wible can't be there for every physician or trainee 24/7. But you can learn from her experience in her 2016 book, Physician Suicide Letters Answered.
Need me to do, and I also refer them to other mental health resources. If I can't help them, I know of therapists that do Skype visits, and people to refer.
Among her more memorable stories, and Dr. Wible will tell you that they're all memorable because they're just also tragic. One story stuck out to me about an ER physician who tried to kill himself.
And he literally was in cardiopulmonary arrest.
He died.
And he was brought back to life.
Thanks to the miracles of modern medicine and high-quality CPR. But it wasn't a straightforward case of a suicide attempt, if you can ever call them straightforward cases.
And this was a letter that he wrote me in the aftermath of surviving.
He reached out to Dr. Wible to tell her what had happened to him and what had changed him.
It's quite a long letter.
But it's worth hearing out.
Here it is. Dear Pamela, I've never been so happy to fail at something in my life. 4 weeks ago today, I died. Cardiopulmonary arrest in jail. Why was I in jail? My wife alerted the police. Sheriff deputies were upset when I did not pull over to talk to them after overdosing. After boxing me in, they threw me from my truck into the slushy street and tased me. After charging me with a felony and 2 misdemeanors, they nearly provided the perfect assist to my suicide. Through a series of miracles, I was brought back. I am missing 4 days of my life, including 3 on life support, but I am alive. I have to repair almost every relationship I treasure from the betrayal of my weakness, a chore I will perform with as much love and patience as I can muster. I may never practice my specialty again, but I am alive. My family has a husband, father, son, and brother. My wife once asked how we do it in the ER, to be there for everybody's worst day and also for their best. My worst day was almost my last. Funny thing is, I was as happy as I had ever been in my personal life. My decision to end it all was 100% work-related. And he's one of the ones who said he was, happy. And this was just like a sudden, impulsive decision minutes before, right?
I had just lost a young girl in the ER a few weeks before. Influenza. I followed proper protocol, gave her a couple of treatments, and she felt better, so I discharged her home with appropriate warnings. 30 hours later, she came back in respiratory arrest. She ended up on life support with family refusing to withdraw care. Blamed me. While my employers were very sorry about the case and stated support for me, the result would likely lead to termination due to this incident and a few other cases that were trivial. I thanked them for their honesty. At first, my wife and I talked about it, and I was fine. I returned to work that night sad, but comfortable with my likely outcome. When I got home in the early morning hours, I was just sad. I cried for the girl and her family. I cried myself to sleep and woke up still sad. There's a saying we have in the emergency room.
When we witness trauma and death among the innocent, we're never offered counseling, and in the end, you just get that jaded emergency doctor who struggles to care.
A little piece of my soul died.
My psychologist says it wasn't just the last girl. It was trauma after trauma after trauma.
Pretty sure I have PTSD from the Haiti rescue and recovery trip. From bloated bodies liquefying in the heat to starving kids begging in the street. Years later, walking into a Mexican hotel with similar tiles and stucco walls, I was overwhelmed by the smell of rotting flesh. Other times, when opening a large pararectal abscess, I could smell dead bodies. Sitting alone with my grief, I grabbed what I needed and drove up to the mountains. I thought my wife would be better off without me. I texted, "I'm so sorry. You deserve better. I have tried to be strong. I can't take it anymore." To have that girl die was too much. To have to face being terminated for it, I can't go on. I'm sorry. I love you to the end of the world and back, but after one final hurt, I can finally stop hurting you. You have your family.
You know, he goes on to say, like, tip of the iceberg, horrible cases, a drug-related killing where a kid was bludgeoned to death with a baseball bat, barely alive when his druggy friends dropped him in the ambulance bay. You know, all sorts of things you can only imagine, right? Crack addict mom that didn't pay up. I mean, he goes on and on and on, which would just, the average person would have a meltdown with even 5 minutes of seeing any of this, right?
I took a handful of pills, then came the police cars. I don't know why, except not wanting to talk to them or face my wife. I continued driving. I obeyed all traffic laws, never exceeded 22 miles per hour, and in no way endangered pedestrians or other motorists. At one point, I pulled to the side, and multiple officers took cover and aimed guns at me. They wanted to know if I had guns. I kept my hands visible as directed, but refused to exit the truck because I did not want to talk to them. Ultimately, I was thrown from the truck, tasered, cuffed, and put in the back of a police car.
And he said, yet I've never been depressed per se.
And never suicidal. I just snapped.
I think that's just, it's heartbreaking. There's not really a word for it.
I mean, he used to be a residency program director in emergency medicine. This guy is brilliant. He's amazing. I mean, to lose him as a physician is a huge loss for everyone. He's absolutely competent. Mm-hmm. He's amazing. And what I love about him now is after surviving this, he's now going public, telling his story with his name and speaking at residency programs around the country to help other emergency doctors in training just understand that it's okay to cry and this could we're all at risk.
Especially if most of these decisions are made without any thought, without any real planning. You know, that's got to be horrifying. Dr. Wible's right. We are all at risk. Pamela, you've got a movie about this coming out soon, right?
Yeah, it's called Do No Harm. It's not my movie. I'm actually just filmed in the movie. The movie is it's a documentary by a 2-time Emmy-winning filmmaker named Robin Simon. She's been filming for 4 years, and it is absolutely fabulous. She cold called me 4 years ago. It was the fall of 2014 when I think you might remember 2 interns jumped to their deaths in New York City within 3 days of each other, and so it kind of hit the the news at that point. And a friend of hers had handed her the New York Times article about these 2 suicides in New York City and said, you should do a documentary on this.
When does it come out?
It's going to debut. I think the premiere will be in New York City in September in association with the Suicide Awareness Month or something like that. But it's amazing. She even has a live orchestra, original music score. And the end of the film, by the way, has this wall of honor where it's almost like a Vietnam memorial list of doctors who have died by suicide by name and specialty that just keeps scrolling and scrolling.
For anyone who's interested, you can find out more about the film and see the official trailer at donoharmfilm.com. In some ways, I guess we've made a few strides in trying to deal with this. For resident physicians, the ACGME requires programs to assess fatigue and burnout among trainees, and to provide access to confidential counseling. At Penn, our residents participate in a scheduled Friday morning, rehabilitation exercise, but they call it a doctoring session, where residents are invited to discuss the issues and difficulties that they face with patient care, with the hospital program, duty hour requirements, and so on. I get the feeling that most residents enjoy it because it's a very unstructured, 1-hour kind of relaxing session, and there's no supervision or intervention by any faculty representative of the department. But I'll say this with a caveat that most efforts like these have been regarded as incomplete by many experts. Mental health remains a largely neglected field when performance measures are so highly respected and resident work hours are so poorly regulated.
It is really nice. I think the retreat that I lead is on 150 acres out in the mountains of Oregon, and it's off the grid, no cell phone service, no internet access, and we really are there 30 or 40 physicians at a time, just being with one another. And
how horrible is it that the first thought that came to my mind was, oh Jesus, how many emails am I going to miss? And how many phone calls and how many call shifts do I have to make up?
Right. Yeah. And a lot of people feel that way. They're like, oh no, if I take a vacation from, their big box clinic, when they get back, they'll have 4 times as much work as they had when they left. Yeah.
Know you've been a good friend, and that's in the thick and thin, and I know it's never gonna end, 'cause you've been a good friend.
Dr. Pamela Wible, everybody. She is the founder of the Ideal Medical Care Movement and author of Physician Suicide Letters Answered. You can hear more from her on her own podcast, Pamela Wible Reports, and from her TED Talk, Why Doctors Kill Themselves. That's all we've got for you this week. Thanks for listening to the program. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. Music this week was courtesy of Andrew Sacco, Damiano Baldoni, Kevin MacLeod, Jason Shah, and Raphael Archangel under a Creative Commons license. Voiceover by Patrick Green. For more information about physician suicide and some additional resources, please check out our blog at brainwaves.me. And while it's been such a pleasure for me to produce these shows for you all, I'm sorry to say that I will soon be spacing out these episodes so I can prevent burnout myself. We'll be switching from a weekly model to a first and third Thursday model. But you can always find more content in our archive of prior shows on iTunes or wherever you get your podcasts. I'm Jim Siegler, and I'll talk to you again soon.